Picture this. You're cruising into your day 3 of 3, Friday shift on the floor. Your patient was perfectly fine just 2 hours ago, but now they're gasping for air, shoulders hunched forward, and their oxygen saturation has dipped to 82%. You're thinking, is this distress? Or are we already past that point? Let's sort this out and fast, so you don't miss that critical line between something that's still fixable and a full-blown oh crap moment. So what exactly is respiratory distress? Think of it as the body screaming, I can't breathe easy. You'll see fast, shallow breaths, maybe 25 or even 30 a minute. Their chest is heaving, they might be leaning forward, grabbing the bed rail in that classic tripod position. Their nostrils are flaring, trying to suck in every last bit of air. Their oxygen level is low, sure, but if you put them on 2 liters of oxygen, they start to perk up. They're still working hard, you can see it, but they're not crashing. The body is compensating, fighting to maintain balance. It's a warning sign, a big, bright, flashing one. Now let's talk about respiratory failure. This is when the lungs essentially quit. They've given up the fight. The compensation mechanisms have failed. Oxygen levels are now tanking, with saturations dropping below 85%. You might even see cyanosis, that bluish tint around their lips or on their fingertips. Here's a key difference. Their breathing often slows down. It becomes shallow, quiet, almost like an engine sputtering out. And the silent killer here is the rising carbon dioxide. This buildup leads to headaches, then confusion, and eventually they can become unresponsive. If you give them supplemental oxygen, it barely moves the needle. This is when you know it's time for more aggressive support using non-invasive ventilation like BiPAP or even intubation. So how do you definitively know which one it is, especially when things are moving fast? The gold standard is to get an arterial blood gas, or ABG. Specifically, you want to look at the PaO₂ over FiO₂ ratio, also known as the PF ratio. In a healthy person, this number is above 300. If it drops below 300, you're looking at mild trouble, like what you might see in early ARDS. If it's under 200, that's moderate trouble, and you need to get ready to act. And if that PF ratio is below 100, you're in deep. That number is your objective red flag, the data that screams, hey, this isn't just distress anymore. This is failure. Why does this distinction matter so much? Because if you spot the transition early, you can intervene and potentially save them from a much worse outcome. You can apply the right level of support before the situation spirals. But if you wait too long, they crash. That means a code blue, an emergency intubation, a transfer to the ICU, and a much more complicated and dangerous road ahead for the patient. So yeah, you have to watch for the subtle signs, the tripoding, the flared nostrils, but also the silence that follows, the blue fingers, the sudden confusion. Don't just wait for the monitor to scream at you. Trust your gut, use your clinical judgment, and call it. Escalate to your charge nurse, call the rapid response team, get the doctor on the phone. You have to move. So the next time you're at the bedside and you see a patient struggling to breathe, ask yourself that crucial question. Are they working hard? Or are they starting to give up? The answer will guide your next steps and could make all the difference. I'd love to hear your experiences. Drop a comment below. Have you ever seen a patient flip from distress to failure really fast? What were the signs you noticed? Thanks for supporting my channel. Stay sharp out there, and remember, you've got this.